Can you all hear me?
Yes.
Okay, I'm going to be presenting about the diagnostic accuracy of rapid assays for diagnosis of bloodstream infections and antimicrobial profiling of pathogens that causes bloodstream infections at a tertiary hospital in Polokwane, Limpopo Province of South Africa. So bloodstream infections, which are characterized by the presence of viable microorganisms in the bloodstream, are a leading cause of morbidity and mortality, particularly in individuals with compromised immune systems. So the mild symptoms for BSI include fever, chills, diminished vascular tone, low blood pressure, changed mental status, hyperventilation, hypothermia, and a higher risk of organ malfunction. And then in critical situations, clinical signs include tachycardia, tachypnea, leukopenia, and death. So according to a study by Deku et al. 2019, about 30 million people worldwide were affected by BSIs, which resulted in 6 million fatalities. And Africa accounted for more than half of the world's cases of BSI, accounting for an estimated 17 million cases and 3.5 million fatalities. Low and middle income nations accounted for about 85% of all cases, and the prevalence of BSIs in South Africa ranges from 5.7% to 17.7%, although there is paucity of data when it comes to BSIs in South Africa. So the most commonly used methods for identifications of pathogens that causes BSI in South Africa are the VITEC2, the microscan, walkaway, or mass spectrometry instruments such as the VITEC MS. The blood cultures are obtained when there is a critical suspicion of BSI, and the gold standard for diagnosing them is the blood culture. However, ambiguous results can be obtained from using blood cultures due to contamination. So blood cultures also have a long turnaround time for results, ranging from 2 to 14 days for identification and antimicrobial susceptibility testing, rendering the results almost clinically irrelevant. Thus, there is a need for a faster and more accurate diagnostic platform for diagnosis of BSI, and thus the rationale of this study was to determine the accuracy and practicability of the diagnostic assays, that is the VITEC2 and BCID2, in comparison to the blood culture in the Limpopo Province in South Africa. So we conducted a prospective cross-sectional study in patients suspected of having bloodstream infections at a tertiary hospital in Polokwane, South Africa from January to July 2023. The study collected the patient's demographics and the blood culture bottles, whereby 2 bottles of each patient from different sites were collected. And for adults, the aerobic and anaerobic bottles were collected. So the blood cultures were incubated in the BD Bactec machine. The positive cultures were then gram-stained and subcultured on the blood agar, chocolate agar, and the makonki agar plates, and then isolated organisms were then ran on the VITEC2 to identify the pathogens and their antimicrobial susceptibility patterns. The positive cultures were also ran on the biofire-form RABCID2 machine to identify the pathogens as well as their antimicrobial resistant genes. So the results were loaded and analyzed on Excel, the types of organisms isolated, the number of positive culture sets, the number of positive bottles within a set, were the criteria used in our study to determine whether it was bacteremia or contamination. So the BCI2, our results with the BCID2 was able to identify the pathogens and the antimicrobial resistant genes within an hour, whereas the VITEC2 was able to identify the pathogens and the antimicrobial susceptibility patterns within 24 hours. So from the 730 blood cultures submitted, the positive cultures which had true pathogens were found to be 33% of all patients' cultures. Gram-negative bacilli were the most isolated with 63%, followed by gram-positive cocci with 33%, and then fungi with 5%. The most common pathogens isolated were Klebsiella pneumoniae group with 16%, Acinetobacter calcoaceticus bamani complex with 14%, Pseudomonas aeruginosa 13%, Enterobacter cloacae complex 10%, Enterococcus faecalis 10%, and Escherichia coli with 8%. The antimicrobial resistant genes identified by the WCID2 were the CTXM with 43%, MEC-AC 24%, NDM 20%, OXA48 like 9%, MEC-AC and MREJ, which confers for the MRSA 3%, and the VAN-AB for vancomycin resistant enterococci with 1%, and VAIL with 1%. This is shown on figure 2, which I'm still gonna show you from the upcoming slides. So amoxicillin clavulanic acid, 88%, cefotaxime with 82%, erythromycin with 81%, and trimethoprim sulfamethoxazole combination with 25% show the highest level of resistance. So children constituted 63%, whereas adults constituted 37% of all the patients. So here, this graph here is actually showing the prevalence of the pathogens that causes the bloodstream infection. So in this graph, I actually didn't include all the microorganisms that we're able to isolate, but instead I only included the ones that were most prevalent from our study. So here, these are the antimicrobial resistant genes. This is what I was talking about from the previous slide. As we can see, that CTXM is the most prevalent here with 43%. So here, this graph here also shows the antimicrobial susceptibility patterns of the different antimicrobials that we tested in our study. And then also here on this graph, I only indicated the ones that conferred the highest resistance as compared to the others that were more susceptible. So on our discussion, the biofilm blood culture identification 2 panel provides faster results as compared to the VITEC 2. It identified the pathogens and their antimicrobial resistant genes within an hour, which will I believe will help the clinicians to get the results faster and therefore treating the patient earlier, which will in turn reduce the mortality that is associated with BSI. The disadvantage of biofilm BCID2 is that it does not identify some of the pathogenic organisms that are found in the blood culture, and some of these organisms that the BCID2 cannot identify but can be identified by the VITEC 2 include Leuconostoc mesenteroid subspecies Dextranicum, Physiobacterium indulgens, Pseudomonas putida, and Sphingomonas possimobilis, amongst others. So the VITEC 2 have a long turnaround time, but it can identify a vast of pathogens as compared to the BCID2, and it can also do antimicrobial susceptibility testing, which will help the clinicians to know which treatment to use to treat the patients, which is something that the BCID2 is unable to do. So although the VITEC 2 can identify a vast of microorganisms, there are possibilities of missing out identifications of some pathogens if you happen not to isolate those colonies from the plates. So gram-negative were the most isolated, as I've indicated, with 63%, followed by gram-positive cocci with 33%, then yeast with 5%. And this is similar to the results reported by Mashau et al. 2022. The most common pathogens isolated were Klebsiella pneumoniae with 16%, Acinetobacter calcoaceticus baumannii complex with 14%, Pseudomonas aeruginosa 13%, Enterobacter cloacae complex with 10%, Enterococcus faecalis 10%, and Escherichia coli with 8%. And this is similar to the results reported by Mashau et al. 2022. But in contrast with the results reported by Keeley and Table 2021. So the high number of the CTXM gene with 43% indicates the high number of resistant to beta-lactam antibiotics. So from our study, children constituted the higher number of all the patients with 62% of the total number of patients with BSIs, while the adults constituted a less number, which was 37%. So this might be due to the difficulty in obtaining blood cultures from children. So this is similar to the results reported by Parajuli et al. 2017. In conclusion, the BCID2 provides a faster diagnosis of BSI as compared to the traditional culture methods and VITEC 2. So the biofilm array BCID2 allows species ID and carbapenemase detection within around 1 hour after blood culture positivity, which is a significant reduction in the turnaround time of the positive blood culture workflow. So the VITEC2 should remain the main assay for diagnosis of BSI, as it can identify
Thank you, Dr. Atalia. Any questions? Please unmute and ask her directly.
That causes BSI. So more molecular methods to identify usage of antimicrobial agents, public health measures, and the use of more rapid sorry, am I still audible?
Yes, now you are audible.
Yes, and the use of more rapid molecular assays. And then these are my references. And then I would like to acknowledge the following.